Unadkat.
Nobody is an
Presentation 49-year male, BMI 21, presented to me in May 2021 in the OPD with uncontrolled sugars. He was having diabetes, type 2 diabetes for 17 years. He was diagnosed, he was already under treatment. He was also having hypothyroidism. Yes.
My memory is not that strong.
So he is having diagnosed as type 2 diabetes for 17 years, and he was already under treatment.
Is it type 2?
He was diagnosed. In case paper was showing.
केस पेपर तो known patient of pulmonary tuberculosis रखे ले अपन मान ही लेगा
No, so that is what we need to discuss in the upcoming 20 meetings.
right
Yes.
see he was diagnosed with NIDDM at the age of
So he presented at 49, so 17 years, so 32.
right so he is fitting where
So that is the first point that I
he is fitting where
basically you need to consider type 1 diabetes, LADA, MODI, and type 2 can also be there, but these are the differences.
he is fitting more in the body
But this is something else that we are going to take it out from this.
okay.
But yeah, the age of presentation in mid 30s or early 30s is the main clinical point that you should be looking at, right? So he was diagnosed on his case paper. It was mentioned that he is type 2 diabetes for 17 years. He was already on some treatment, which is the treatment we are going to discuss now. And
He was not ketone diet.
By this presentation, in last 17 years, he had not a single episode of ketosis. Not a single episode. Not ketoacidosis, not even ketosis. So, and also having hypothyroid disease also point to be noted. And of course, we have to
what kind of hypothyroid
primary hypothyroid.
autoimmune or not autoimmune
Yeah, but at that time, for 8 years he was diagnosed, so there was no autoimmune workup was done at that time, right? But unless and until proved otherwise, if it is hypothyroid for such a long period, it is autoimmune illness. Unless and until proved otherwise.
because one autoimmune disease
Yeah.
likely to have other autoimmune disease.
So you already did the diagnosis, but this is the main two clinical points that we should be taking on. Thyroid and type 2 diabetes, this is the history that we have. Of course, we always need to ask this last sentence to each and every patient in post-COVID era. So he never had COVID-19 illness, and at that time he has taken 1 dose of COVID vaccine that we are talking in May 2021. So what is the reports? His HbA1c of more than 14, fasting year 300, prandial year 500. Okay. So he was diagnosed in 2004-2005. Okay. Up to 2015-16, he and his doctor felt that I am very well controlled because his HbA1c was in between 7 to 8. So not his doctor, neither the patient, anyone were concerned. It's going good.
Right, doctor.
In 2017, after 2017, his HbA1c started little bit worsening. In between 7 to 8, which was coming previously, it has now jumped into 8.9, 9, around 10 sometimes. And in 2020 end, it was 11. And that was the last report before May 2021. It was there in his file, right? And the current medication, it was on glimepiride 8 milligram. Okay, teneligliptin 20 and pyroglitazone 15. Unfortunately, he was still not on metformin because at the start, when he was developed diabetes in 2004, he had some diarrhea, and he and his doctor felt that it is an allergy to metformin, and never he was given metformin again. So this is still very common practice. Many times you see in your clinics, right? एक बार metformin की diarrhea था तो lifelong ना let go डाली जाए. बस we did just a bit of counseling there.
But his BMI was not high.
Yes, his BMI was 21, right? So this is the main clinical points, okay? And he was euthyroid on 75 microgram, and that was fairly stable for last 6 or 7 years.
What is the feminist?
Avishek.
Undergraduate छे.
Avishek. So fasting 300, prandial 501, HbA1c of 14.6. So most of you have already get the senior physician know, but if anyone would like to have how to operate this particular case, what you want to do in this patient, Probably these are the most common things that everybody would like to want. But anyone want to coin any particular thing? Yeah, I will add this, I will add this, will add multiple of things.
Before adding, you require some amount of investigation. I
Yes.
think here we are not treating the patient, we are diagnosing the patient.
Okay.
Treatment is altogether is a different. Once you have diagnosed, treatment is so easy.
Perfect. Perfect. So that option is also there. Needs further evaluation and discussion. So that is number 4. So sir has opted for number 4. But at this level of HbA1c, you need to give at least something. You cannot send him home. So what you want to start? So insulin. It's an anonymous decision. The insulin to देवुच person, right? Metformin. Anyone would like to add?
Why not try?
Why not? Okay, then yes, metformin is an option. And the newer analogs, GLP-1 and SGLT2 inhibitor. So the most important point is insulin and needs further evaluation. That is what you should be looking at, right? So anything else? Any other investigation you want to tell, sir? Which investigation to be done straight away?
I said first we take families.
Okay.
You can get some clue.
Okay, it is coming in the slide, but I will tell you family history. His mother is having type 2 diabetes. His brother is having diabetes, older brother. One younger brother and one younger sister are not having diabetes. In mother's side, mother's parents, that is his maternal grandparents, maternal uncles and maternal aunties, nobody is having diabetes. This is the family history.
This fact.
Father side, nobody is having diabetes.
Only 2 generations of that.
Only 2 generations,
No
not 5
history
generations.
no history of chicken pox or
Nothing,
viral disease.
nothing. But a pancreas is absolutely normal.
Looks normal.
Looks
Any
now
recent,
evaluated also.
any recent weight gain or like
Insulin
that?
level.
When he was diagnosed in 2004, his weight was 70. Today his weight is 68. And these are his words that all throughout his life he has been in between 67 to 70. That's it.
Is he a catabolic process or an anabolic process?
He is not losing weight. He is stable. Absolutely stable. With this HbA1c, his weight is not reducing.
So weight neutral.
Weight neutral. Absolutely. So whatever something is going on which is very slowly, that is metabolism is not going into catabolism. That is Sir's point, right? So now any particular investigation you would like to point? Anyone?
Insulin level, C-peptide level, and even though urine doesn't show ketones, do ketones in blood.
Okay, great. So,
HOMA index also.
HOMA index. Okay, so
Sometimes it's
HOMA.
a combination.
Okay, perfect. So you got it right. We want to see whether insulin is being produced or not. That is the main thing, right? So now, suppose we do insulin level or C-peptide level at such a high hyperglycemia. Are you going to rely on it? Because there is a terminology called glucotoxicity.
See, I think it will not affect because he has been pushed on so much of glimepiride, there is glimepiride fatigue already. Pancreas are not responding. So the baseline insulin levels will come.
Okay, so according to you, baseline should come. So I buy that point. Even at that time, I was also having this particular idea in mind when I did
This is
this.
glimepiride induced fatigue also.
Agreed.
It has jumped to 14.
So are you expecting his insulin in higher side or normal side or lower
In
side?
fact, in this fellow, there is no medicine. Except pioglitazone, there is no medicine there.
Exactly. Agreed.
He is the lucky.
So at one end you are thinking that there is no insulin. At one end you are thinking that insulin sensitizer is working.
He is lucky.
No, it is just
He
It's
has
a
not
medicine.
the only medicine. I don't know.
Okay.
But glimepiride is not working, that is for
The
sure.
only thing is his blood ketones are negative.
Blood ketones and urine ketones are negative.
Blood ketones are negative. Some amount of insulin he is producing that is preventing ketosis. So at least insulin level, I don't want to comment on high level or low level,
Okay.
but some amount of insulin.
At least some insulin is there, right?
Exactly.
So this is the C-peptide report. At fasting of 300, his C-peptide is 1.1. And if you see the range, this is the Toprani report, so we are going to believe whatever it is. So the range is also 1.1 to 4.4.
On the lower side.
So it is in the lowest normal range, right? So what is the interference of this particular report? Are you going to think that is insulinopenic or is becoming insulinopenic, or you are going to think that because of glucotoxicity pancreas is not working, but once you control the sugar your pancreas will start working and C-peptide will increase? counting, sir. This is on this only. The C peptide lowest normal range. This is at
Because-
highest provocation.
Hypothyroid. So once again I am asking.
Yeah, agreed. But on this, the highest provocation, the C peptide is in the lowest range. So suppose we are achieving euglycemia with any mean. After achieving euglycemia, what response you are expecting? Whether it is going to improve or not? So he feels it is going to improve little bit.
Depends on the cause.
Depend on the cause. Okay.
These two people premature to ask at this stage.
Okay, chalo. So there is something, some insulin is there, and what we did with this patient at this moment, we have stopped evaluation. We just discussed what I have discussed, that I will tell you later. So probably you will not get what I have started. So we have started a basal insulin. I have started the metformin as well. One SGLT2 inhibitor was added, and 10-leptin was removed, and better DPP4 was given. So this is the prescription, as you can see, Besogene, Jardiance, Jaltra-M, right?
My question here is to all of you. Because with this report and with this kind of uncontrolled diabetes, will you give insulin like this, or will you put continuous insulin infusion so that his pancreas gets rest for few days or maybe week, and then you will start this? This is my question.
That point was agreed with, discussed with patient, and he never wanted any other
And
insulin.
this is what is ideal. See, this patient is going to say everything. Now you are discussing the case.
Yes.
In this patient, I will put continuous
So basal bolus insulin is the best possible regimen in this patient without any reasonable doubt. But since we are expecting some insulin is there, probably it is going to improve. His diagnosed with type 2 for 17 years. So to take any of this decision will take little more evidence.
toxicity. Ideal thing is
Short acting.
short-acting continuous insulin.
Agreed.
Insulin.
But with this regimen, with this
Five
regimen,
times and short acting.
yes, with this regimen, what is happened actually? After 20 days, this is the report. You can see the first report was on 6th May. On 27th May, it is this, right? It was 107 and 201. It was reconfirmed on same regimen after 1 month, 116 and 162. Right? So you can see the date, it is almost now end of June. Right?
We do see very dramatic response with SGLT2 because there is an insulin sparing here. So this possibly is a combination because 10 units of insulin you don't expect this many.
Exactly.
So
So major effect came because of SGLT2 inhibitor, right?
how much weight we can lose in one?
Another thing.
No, not at all. 500 milligrams, 500 gram only.
He had not received till date any medicine which acts on insulin register.
Yes.
So you had started with
How can I start?
It doesn't
I said
know.
bio was one.
Bio
So to start SGLT2 inhibitor till date in my small practice of 10 years, it was the most gutsiest decision I took at that time because I wanted sugar to come down, right? And he was counseled day in and day out regarding probable development of ketosis, home management, home checking, everything. But yeah, at the end of 2 months of therapy, he is at this level. So should we end here or we should do something else as well? Because the control is such, patient is least concerned to come for follow-up as well.
If this happened in 6 months, if this would have happened in March, April, then SGLT adding would have been extra work.
Yeah, yeah, of course. Of course. Even is in May, so May is in the most worst temperature wise, right? So it
The
was the
thing
most
is that
crucial decision
you have to
taken.
do something because the diagnosis is not clear.
Not clear, right? So it was another headache for me at that time that by Lord's grace we could achieve very good control in you, but the real story should start now. So the discussion with patient was done. Because of this thing, you were asking that the family history, mother is having type 2 DR, brother is not having diabetes, other two brother and sister is not having diabetes, maternal grandparents, uncle, aunt, no having diabetes. So that absolutely rules out MODI at least because there is no 3 generations are involved, right? So weight at the time of diagnosis, as sir was asking, was 68 and maximum weight is 70. So he was just in between these two over last 2 decades, right? He was not having acanthosis nigricans. 17 years of DM and there was no acanthosis nigricans, right? So what it should be? So what investigation at this moment would you like to do after achieving euglycemia?
The problem here is that you could have done insulin level before giving insulin.
No, the C peptide is equivalent in insulin level. So it was at the lowest normal range. So would you like to do anything else after achieving euglycemia?
why do we do insulin levels? How do you say that both are the same?
Yeah, that's again matter of debate.
Then we go never do insulin levels.
No, no, see, sir,
And if insulin levels you don't do C-peptide. Why what different?
no, see, still people are following C-peptide more than serum insulin levels. The fasting C-peptide and basically what they try to understand,
Why do we do insulin?
because
It's just a test availability.
now the half-life of insulin is very short, right? So if you provoke or if you have hyperglycemia related insulin level, it may not be exactly reflect the insulin secreted amount. So C-peptide is preferred above is insulin, right? But the point is, in this patient, where C-peptide was in lowest normal range at highest possible hyperglycemia, now achieving euglycemia, what you are going to expect, right? So the C-peptide repeated was this. So when we did rest to his pancreas, the C-peptide went absolutely in lowest possible range. Right? So then comes the actual needed test and survey asking, and which is this. Ilex this आपने पहला GAD antibody.
Okay.
GAD is in 60 to 70% of cases GAD comes positive. Then insulinoma, then islet cell and zinc transport, and there are few others newer ones. So his GAD antibody level was strongly positive, but that IDC, as you can see the date, it was in August. It was ordered in July because it took me whole month to making estimate this 3,000 rupee test is needed in you. He was very reluctant to do this thing because he was concerned, sir, આટલું તો મારું કંટ્રોલ છેલ્લા 6 વર્ષમાં ન થયું, મારું તો થઈ ગયું બધું. Right? So antibody were strongly positive, and then the diagnosis of LADA is STEM. So he is basically latent autoimmune diabetes of adults. So that is nothing but slowly progressive type 1 diabetes, which generally comes in the picture in 30s, but most of the time it is missed at the time of diagnosis. Then it was missed in this patient for 17 years. He was thinking it's type 2 diabetes. Even his doctors thought that it's type 2 diabetes. What are the characteristics? Also known as type 1.5 diabetes, right? Onset is near 30. Some literature says near 35. Okay, doesn't require insulin in early months to years. So that is the most important hallmark, and that is why we generally miss it, because its presentation is not ketosis or not the severe hyperglycemia that we tend to see in the type 1 diabetes straight away. So he must have come with HbA1c of 6 or 7 that we seen in the earlier history. So he was managed with OH. He also responded to OH as well for a few years to few months, right? May have insulin resistance feature because you are having LADA in your body does not preclude that you cannot develop obesity, that you cannot develop eating bad habits. You can still have insulin resistance over and above your LADA. So there can be some confusion in clinical picture if you just rely on the science. So this patient, there was no acanthosis nigricans, but it is very clearly mentioned in many literature the LADA patient may be having acanthosis nigricans, but because of his acquired lifestyle, not because of LADA. Right? So eventually this patient needs insulin. Okay, so sooner rather than later, or probably in this decade, he will be on entirely on nasal bolus because we have seen that the pancreas reserve is still not there. Okay, positive antibody is the diagnostic hallmark that we need to see. So GAD antibody was present in our case. Islet cell, insulinoma antibodies, zinc transporter antibodies. These are the antibodies that we need to see in this patient. And presence of other autoimmune illness. He was having hypothyroidism.
Hypothyroid antibodies.
So hypothyroid, so that was also autoimmune, though I have not checked for it because it is another money-sparing investigation, but I am sure his NTTP or any other thyroid antibody level must be positive, right? So even today, it was surprise to me that he still managed on this particular regimen. I need not to increase anything in last almost 12 months, and this is his last SMBG report. Okay, this is in April itself. So his fasting is absolutely controlled, post breakfast is good, post lunch is acceptable, post dinner is absolutely fine. He did not have single episode of hypoglycemia documented, not symptomatic, anything, right? So it was little bit surprising, but I guess it is very slowly.
Do you actually want to get basal insulin off the block?
No, not at all. Because it is going there, but I have done.
Things are going to every.
Yeah, I have done his CGMS, I have done everything, but he is not developing not a minor hypo. So I am okay with I have done CGMS.
80 is a pretty good cutoff.
Can I put a point?
Yes, sir.
The story does not end here.
Yes.
Every time this patient comes, seek for other autoimmune disease,
Exactly.
right? It may be Addison's disease.
Exactly.
It may be liver.
Anything.
It may be iron deficiency because of the
Pernicious.
celiac
Celiac. Pernicious.
iron deficiency because of
Yes, yes.
means that keep the mind very open for this.
I am fortunate this is a male person. If it is female, then other arthritis and all other rheumatoid and everything might be coming in the picture. But this is the last follow-up I did last month. He is doing absolutely well on the current regimen still. Okay. So this is the glucotoxicity that we discussed. That in chronic hyperglycemia, excess glucose goes intracellular in beta cell. Okay, it disrupts your endoplasmic reticulum and mitochondria, and there is some beta cell dysfunction. But provided if you achieve euglycemia in time, this beta cell dysfunction may be reversible. So many a times you see the reverse response is that you were expecting that C-peptide will increase, but unfortunate for us that C-peptide doesn't increase and we catch it. If it would have been increased, then I would still be in dilemma. What is to be done? In spite phenotypic is LADA, but if C-peptide from 1.1 is gone to 2, then we will still be in confusion that what it is, right? So this is the clinical implication that during hyperglycemia your C-peptide may be anything, but always you need to repeat C-peptide while you achieve a good euglycemia, preferably with insulin or any other modality that you feel so it is not contraindicated in this patient, right?
Here in this treatment, you have tried all of this. Now, this sometimes is in the word better for the patient. So, if you would have done, as I said, insulin, or if you would have done HUMA, you would know whether metformin is the trick doing or the HCL doing insulin. Now, which one to take a step back, you don't know.
Metformin, definitely. He is not having insulin resistance, there is no hyperinsulinemia, your metformin is not going to help. But currently, it is everything under control, so I am not doing anything. But once we start failing, the metformin is the first term, DPP is the second term that we are going to taking up. Right? And SGLT I have to discuss extensively to get it continued. Because ultimately we must be in insulin in the upcoming years. Right? So SGLT is again a very big risk in this patient.
You know, these patients up to 50, 55 don't go to insulin, sir.
Yeah.
I have 90 of them who are not on insulin.
If you think of a recent data, SGLT2 inhibitor and GLP-1 agonist are the cardiorenal protective. You see, so at this age,
You need that.
I would aid that thing for a long-term future of the patient.
Yeah, so that is why it is
Metformin
being
has
kept.
not demonstrated this effect.
Yes, definitely. So, with all the risks, I would like to continue SGLT, but yeah, time will definitely come that it will be a risky molecule. No matter cardioprotective is there, but decay and all other complications may catch up the patient.
You should be observant. See,
All throughout the life of this patient, all throughout.
It is not as bad as people think. DK. We have hardly seen a very few patients with DK. If they are observed, as I said,
Only thing when
only patient losses to follow up to it.
I have seen almost 35 to
Along
40.
with metformin is likely to produce decay in a very
35 to
very
40
not-
patients. Unfortunately, what is happening, sir, since because of effect of SGLT2 in non-type 2 diabetes patient, in heart failure, in ASCVD, in CKD is coming, people are using date and I am getting reference of perioperative sugar management. Second day post bypass, cardiothoracic surgeon has started empagliflozin. On third day they are in decay.
because of starvation.
Of course, so people do not understand.
As I said, unobserved.
Unobserved. So people see, most of the time in this patient we are not the prescriber. Somebody else has started the medicine and we have to unfortunately get the frustration of decay, because once in a patient I needed almost 4.5 to 5 days to take out IV insulin in patient who developed euglycemic ketoacidosis because of empagliflozin. Okay. And it was started by
in cardiology.
the
there
most
are
famous
metformin-
cardiothoracic surgeon of Ahmedabad.
No, no, hear me. Everywhere. The cardiologist suddenly started using left.
They are using like anything, anything, and it is even more troublesome that the patient is on secular Versatile as well. They are on SGLT2 as well. Both are branded, so you can imagine the cost.
And your beta blockers to block everything.
So as a patient, you can imagine what is the
You
situation.
want to continue DPP before you?
Now I am going to stop as and when the hypoglycemia is recurring. The DPP and metformin are out of board anytime. This has been discussed with patient because he is in airport authority. The
But
medic.
you know, both of them don't cause hypoglycemia.
It do not cause, but there is no need of them in insulinopathic patient. How you want to continue DPP4 and metformin? It's not needed.
Yeah.
But somehow we achieve control. Let it be. Patient is happy. I am happy. Better ends there.
Good, very good.
Very good. So there are some CGMS cases if you want to see. We have 5-10 minutes. Should I?
Yeah, बताइए.
नहीं तो બીજું આખું સેશન રાખને
આખું સેશન રાખું CGMS. હા એટલે થઈ જશે. There are plenty of cases. These all are
એટલે
CGMS.
બીજું ડાયાબિટીસનું સેશન રાખ
अरे बाप रे. हाँ sir, as you said, these all are CGMS cases, but
So
2-3 are there that which can.
so that we can discuss at length. This is what I do.